Oh, I'm Dr. John Kruse, and today I'm going to be talking about ketamine and ADHD. Can it really help? As usual, I'll start with the take-home message, and then in a minute or two, jump into the main meat of the story. So the take-home message is 3 big points. One is ketamine, right now in 2024, is well established as working quickly, effectively for depression, particularly useful in treatment-resistant depression or for suicidality. 2, ketamine clinics are a huge business in the U.S. That's a business on the order of $3 billion or so. So there is huge incentive to be driving new uses, finding new patient populations to treat. And 3, despite numerous clinics that advertise for treating ADHD with ketamine, I have been able to find not a single clinical study investigating any benefits or finding any benefits for ketamine for ADHD. So that's the take-home message. Jumping into the main story. So ketamine is a synthetic anesthetic. So it was developed in the very early 1960s. It's a derivative of PCP or phencyclidine, which was being used as an anesthetic at that time. PCP was pulled from the market as an anesthetic because it just so often had floridly psychotic, crazy delusions, paranoia, hallucinations, that it was not felt safe to continue using it as an anesthetic. So ketamine was designed specifically to hopefully cause less hallucinations compared to PCP. It does. It's what's called the first dissociative anesthetic, and that is it created a sense of dissociation or separation from the mind, or the consciousness felt depersonalized, derealized in a trance-like state, separate from its anesthetic properties. So at low doses, ketamine has hallucinogenic effects, it has dissociative effects, and these are both lower than the anesthesia effects. And ketamine is both an anesthetic, which means it's putting someone in a subconscious state, less than conscious state, and it's an analgesic, meaning it is also directly helpful for pain. So there are anesthetics that don't do much for pain. There are analgesics that don't knock you out. Many of our anesthetics do both. So this is, again, both an anesthetic and an analgesic. And one thing that differentiates ketamine from other anesthetics is that most of our other anesthetics are just overall sedating. So not only are they sedating consciousness, brain level, arousal systems, they're suppressing or depressing heart rate, blood pressure, respiratory tone. That's why people need to be intubated when they're on anesthesia. So airways can collapse. Ketamine causes much, much less respiratory collapse or decreased cardiovascular tone. So there's much less need for intubation. There's much less worry about someone going into shock, blood pressure dropping so low that blood flow isn't getting to the brain. So it's particularly prized anesthetic in the realms of trauma situations on the battlefields, in the ER, where also dealing with lots of head trauma and situations where decreasing blood pressure is a potential big problem. And it's still continued in pediatric anesthesia, partly because if intubating kids is much smaller airways, it's much trickier and more difficult. Again, less need for that with ketamine. And it's used in animal surgery. So when I actually did my PhD work in the 1980s, ketamine is what I used to anesthetize hamsters for my research. So from the 1960s to the year 2000, that was the use for ketamine. It was as an anesthetic. It wasn't used outside of that much, except there was also some leakage into the party scene, the rave scene. So ketamine, or Special K, usually consumed as a powder or pill, or snorted even, was used for hallucinatory trance-like experiences. And one interesting thing about the hallucinatory experiences, which was often referred to as going into a K-hole, is that fairly often those resembled reports of near-death experiences. So it's not completely clear why that's so common with ketamine or what it taps into, but that is an interest of ongoing concern. The other thing is, in my recollection, is that there was at least one sort of warning. Ketamine wasn't a huge or major drug on the rave scene, but there was a warning that based on animal models looking at propensity for addiction, that ketamine was something that the law enforcement and other medical community needed to be aware of, because there could be major ketamine addiction problems given how addictive it seemed to be in at least one study. So then in the year 2000, there was one study. They only looked at seven subjects. It was open label, so the people knew what they were getting. The doctors knew we were giving it to them. So it gave 7 depressed people ketamine, and they had pretty rapid, remarkable antidepressant responses. You would have thought that would have kicked off a huge wave of exploration, research, and use of ketamine, because even though many millions of people are helped by current and at that time available antidepressant medications, clearly a substantial portion of people with depression don't get adequate help from the first or second or even third antidepressant they try. And at that time, all of our conventional antidepressants would take several days to a few weeks to work, rather than ketamine seemed to work within hours. But it wasn't actually until 6 more years that there was another study. This one was actually a placebo-controlled study, so more objective evidence that it worked so much. Only 18 subjects, though, but the ketamine worked so clearly and robustly, and again, within hours, to alleviate treatment-resistant depression. That's what kicked off the wave of research, wave of ketamine clinics' use of it. So by 2015, there were 60 ketamine clinics in the US. By 2018, there were more than 300. Now they've gone through significant mergers, bankruptcies, takeovers. That's a very volatile field. But as I mentioned in the intro, as of last year, it's at least a $3.4 billion business. And not that there's a shortage of people with depression who are still in need of adequate treatment, but this is clearly a drug in search of bigger markets. What else can we treat? So there is a fair amount of evidence that ketamine can be used for treating pain syndromes. There's evidence it can help some individuals with PTSD and anxiety issues. So there are some other uses which are suggested. One important thing to point out is the people who run the people who are the best entrepreneurs or salesmen are not always the best clinicians or doctors or therapists. So how does ketamine work? So ketamine works on lots of different receptors in the brain, but it works quite strongly at tiny, tiny micromolar doses on the NMDA glutamate receptor, and it's a blocker of that agent, of that receptor system. So the assumptions early on, and still in large parts of the field, is that this works quickly as an antidepressant because it's a glutamate antagonist, glutamate blocker, NMDA specifically blocker. However, numerous other drugs, including memantine, which is approved for dementia, have been studied for their effects on depression. None of the other NMDA blockers seem to be immediate antidepressants, and most of them don't show any convincing, even delayed effects on depression. So how does it work remains largely unknown. In addition to the NMDA glutamate receptor, there are actions on cholinergic and opioid receptor systems. It works on a number of different ion channels. Some people have suggested that it's actually not the ketamine itself that's important, but maybe one of the metabolites, the breakdown products of ketamine, that as having the quick antidepressant action. There was interesting research from Stanford probably 3-4 years ago, at least now, and to my knowledge has not been extensively replicated, where they treated patients with naltrexone, which is a opioid blocking agent. And so if they pre-treated patients with naltrexone, that was able to block the ketamine antidepressant response, while interestingly, it did not block the dissociative effects of ketamine. So people still had sort of out of touch with their body, depersonalization, derealization, and some, I think, even hallucinatory effects without antidepressant effects. So that claim, that study seems to suggest that the action on the opioid receptors, particularly the mu opioid receptors, seem to be important for ketamine's antidepressant effect. However, a few studies with other mu opioid agonists also don't find quick antidepressant effects from them so far. So the precise mechanism of action is unknown and probably complicated and undergoing lots of active investigation, because if we figure out how ketamine's working, then presumably there will be other agents that are working similarly, maybe with milder or better side effect profiles or maybe longer durations of action. So when ketamine helps for depression, the effects are usually someone feels a lifting of mood. So the most common research has been done on injections. I'll get into that over the course of about 40 minutes to an hour. Mood improvement seems to be measurable within 2 to 4 hours after that injection, and peaks around 24 hours after that. For most people, there's a gradual fall off over the course of a week or two, but many people are still seeing some benefit in mood even a week out after a single injection. So the FDA has not approved ketamine injections for treating depression. This may surprise people when there are, again, over 300 clinics in the US offering this. So again, the FDA approved substances. Ketamine is approved as an anesthetic. Then doctors are allowed to use that substance for other indications if they feel that there is medically sufficient evidence that its benefits would outweigh the risks. And that's how ketamine is being used so far. There is one approved ketamine form of ketamine I'll get to in a minute. So partly because there's no standard FDA recommendations, there's no clear uniformity. Clinics are welcome to do whatever approach they think works best. Somewhat of a standard is a 40-minute intravenous infusion. So not an injection, infusion, because an injection is usually a single shot pushed into the body, but an infusion is dripping in by an IV at about 0.5 milligram per kilogram. So the average American, that might be about a 40 milligram dose. And the standard is that person should be monitored for the next 2 hours after the treatment, not just for potential hallucinatory psychotic episodes, but also because effects on blood pressure. So ketamine can acutely lower blood pressure dangerously. There's some people who have rebound increases in blood pressure, hypertension in the aftermath. And many people find, even if they're not psychotic, that the hallucinatory experiences are unpleasant or scary. So that's additional reason for monitoring. Now, given that the effects do wane, the standard approach, again, isn't completely standardized, but most clinics are administering at least 2 and more often at least 3 treatments a week for several weeks. And then if someone has a thorough and apparently sustained antidepressant response, the approach is to back off on the frequency to once a week or once every 2 weeks, and then at some point potentially stop treatment. In some clinics, people remain on any oral antidepressants they were already taking. Some clinics require people to get off of those. So again, there's not a lot of standardization. And in addition, that 40-minute infusion, again, isn't something every clinic has to follow. So clinics that want to churn people in faster do things like an IV bolus. So that's where the whole 40 milligram dose is sort of pushed in quickly over maybe a minute with the syringe. Or some clinics, and often pain clinics, are using IM or intramuscular injections. And they're also using subcutaneous injections, so under the skin. And even less well established, but clearly more patient acceptance and less medically intensive work is oral dosing. So this is available as an oral form. There's more divided evidence on the efficacy. So some studies of oral doses didn't find an antidepressant effect. The proponents of the oral form claim with good justification that you need a substantially higher oral dose. It's just less biologically available, less of it. You have lower blood levels from an oral dosing than from a IV injection. But if you take a large enough oral dose that its success rate is as high as it is for a 40-minute infusion. So oral dosing is probably going to become increasingly more popular just because it takes less work and less involvement, even though, again, none of those are approved. The one FDA-approved form of ketamine for treating depression is a nasal spray that's available in the brand name Spravato. And that specifically, so ketamine, like most of our drugs and most of our organic molecules, is equal amounts of left-handed and right-handed versions of the same molecule. The Spravato is only the S version, the sinister, the left-handed version of the molecule, and it's interesting because there's conflicting claims. Some of it may be differences between human and animal research. Some evidence suggests that the S is a much stronger NMDA blocker than the R, but not all the studies have suggested that, and some also question which is more effective for treating depression. And again, there may be human-animal differences. Not a lot of large number, extensive studies conclusively show one way or another. So Spravato is FDA approved, and it is approved only under special sort of FDA permission process, in that a clinic that uses it has to show that they have the capacity to monitor blood pressure and heart rate, and that they will have the capacity to monitor someone for at least 2 hours post-infusion or post-nasal inhalation. So they're not supposed to treat a patient and just stick them in the waiting room while a single therapist office is moving on to the next patient. However, those guidelines are clearly widely abused. So within the first month of Spravato's release, I saw patients in San Francisco who had gotten Spravato from other providers and were given it as a take-home medication to just use it the privacy of their own home, and whether they were monitored for psychotic, hallucinatory, dissociative experiences or blood pressure issues was totally on them. I should point out furthermore that the Spravato was only approved for treatment-resistant depression. So theoretically, you had to have a lack of success at therapeutic doses of at least 2 other antidepressants before you qualified for Spravato. Nasal spray forms of S or the racemic mixture of both S and R forms of ketamine are available through compounding pharmacies. So these are where the pharmacist itself is mixing up the preparation and putting it in an inhaler for use. That often can be cheaper than Spravato, but the FDA did issue a warning earlier, I believe it was in 2024, it might have been late 2023, that several of these products were found to be contaminated, and there's less rigorous FDA and DEA intervention surveillance of the day-to-day workings of a compounding pharmacy. So there may be risks in terms of you might be inhaling things you might not want up your nose. So separate from depression, where this is clearly a rapid, effective treatment for many people, like all treatments, it doesn't help everybody. There seems to be actually particular niche for reducing suicidal thoughts, and there's at least one study where statistically they could examine decrease in suicidal thoughts versus improvement in depressive symptoms, and it's found, at least in one study, that the suicide reduction was not just due to depression getting better very quickly. It was actually a separable, identifiably distinct action of ketamine. So when ketamine came out, or Spravato, it was heralded as the first fast-acting antidepressant. And we do have another agent now on the market in the US called Auvelity. That's an oral pill, combination of bupropion and dextromethorphan. I do have a talk on it in this video series. Auvelity often works within a day. So ketamine isn't alone in working quickly, but I am sort of aghast and disappointed that more than 90% of the popular literature, New York Times, other articles, but not just that, the medical literature, the psychiatric literature has proclaimed ketamine, what's so wonderful because it's the first oral antidepressant we have that worked quickly, or first antidepressant of any delivery system that worked quickly. And this is ignoring something that actually many people with ADHD may be more aware of than the experts on depression. And that is, we have more than 70 years of rigorously done good studies showing that stimulants can have antidepressant effects, and that's both methylphenidate, Ritalin products, and amphetamine, and that they tend to work very quickly, within a day. Most of the research on this was restricted to patients on consult and liaison services, or not on a psych ward, and reserved for people who had cancer or some other terminal condition, because the concern was that either tolerance to or addiction to stimulants would be more of a danger or more of a risk than getting out of your depression. And even though depression itself can be a life-shortening illness or process. So I don't know why there's so much ignoring of the fact that stimulants can have immediate antidepressant effects. Some of it is that some of the doctors claim they're not really having antidepressant effects, they're having euphoric effects. They're making people giddy and silly, which is in itself a risk factor for abuse addiction. But in the patients I've seen treated, very clearly methylphenidate at least can have antidepressant actions without creating euphoria, without creating a high, without creating craving or an expansive sense of, or an excited sense of anything. So I'll move on from that topic to what are the side effects of ketamine. So about a quarter of people in studies have side effects with ketamine. Nausea is moderately common. Some people are also have vomiting. Dizziness can happen, blurred vision, amnesia. Usually it's not total losing your memory. It's memory for the events around the time of the infusion itself. We've talked about dissociation, so feelings of unrealness and depersonalization, where you don't feel like you're yourself or you're a person at all. Hallucinations, and again, usually those are visual hallucinations. They can involve paranoid thinking. Usually the hallucinatory period is during the infusion itself. And there's some disagreement in the field. I think the weight of the data is pretty strongly that you can have an antidepressant response to ketamine without any dissociative experience, without any hallucinatory experience. However, there's quotes in the popular press about clinic directors and ketamine clinics saying, oh, I dose everyone up until they're hallucinating and I know they're going to have an antidepressant response. I think they've seen more people getting infusions than I have, so I don't want to challenge their personal experiences and what they've seen, but I don't think they're using a scientific evidence-based reasoning in that. So one concern about ketamine is particularly taking it during pregnancy, and at least in rodents, what's interesting regarding the ADHD ketamine connection is that pregnant rodents who are given ketamine have pups, kits, whichever little baby rats, mice, others that actually look like they have ADHD. So they have more hyperactivity, they have more distractibility, so that would suggest ketamine is something to stay away from. What's important is not only are there species differences, even within species, ketamine, so even within animals, so ketamine is much more likely to have psychotic-like experiences in adults than it is in kids who are receiving it for anesthesia. Other side effects. There clearly is some potential for addiction with ketamine, and the death of Matthew Perry several months ago, the actor, is testimony to that. So part of it is that people who are taking this either for depression and maybe more studied for pain control develop tolerance pretty quickly. And again, pain control is an off-label use of ketamine right now, but widely used. So again, you can certainly develop tolerance to a substance without developing addiction, but most people who become addictive do become tolerant first. So how risky it is unclear. There's a number of case reports in the psychiatric literature that have been written up for people who had long-term depressions, which ketamine was the first thing that alleviated that depression. But then when they stopped treatment, intense suicidal ideation, maybe more pervasive, strong, scary than it ever occurred to them, was there until they got back on ketamine, which suggests, at least in that some population we are setting them up for, they need to be taking it for life. So jumping over to what I'm supposed to be talking about or focusing on is ketamine any good for ADHD? Now, there's a little bit of basic science research that boosting glutamate and GABA may be helpful for ADHD, that there may be some dysfunction of NMDA receptors that may underlie ADHD. And yet, and I found at least a half a dozen sites pushing specifically ketamine for ADHD, and all of them said something like, it has also been studied for its effects on ADHD. So this talk is actually a re-recording because of audio control problems of some talk I gave in November of 2023. And I double-checked PubMed. There is not a single clinical trial study, case reports even, of ADHD being used or being treated with ketamine. Just none. So there's certainly anecdotal reports. And yet the claims are one claim. It will help your brain manage the inattentive, impulsive, and hyperactive behaviors that are the hallmarks of ADHD. What did another one say? I guess that it boosts glutamate and GABA, so that's going to help your ADHD. So if you look on online forums, again, a highly interesting way to find a range of responses or what people acknowledge was their experience. But it's not a good way to collect any systematic data because you're getting skewed populations. But when I've looked at several different online forums, I could find dozens and dozens of people with ADHD who said, and mostly they were taking ketamine for depression, said, no, I didn't see any improvement in my ADHD, didn't see any change, no impact, whether or not it did or didn't help their depression. There are one or two wildly enthusiastic endorsements. Some of the interest in ADHD being treated with ketamine came from, I believe it was an NPR segment in 2018 with one man who had ADHD and a dramatic response to ketamine. There are also a handful of people who said, I thought I was dealing with ADHD, I had ketamine treatment, and what's become very clear to me is that my ADHD symptomatology were primarily, or if not entirely, depression and anxiety, not ADHD. So perhaps sloppy diagnostic assessments are responsible for some of the clinicians thinking that ketamine helps with ADHD. It may really help, but at this point in time, I certainly can't endorse it or recommend it to people. I mean, my own limited experience with patients, I've had at least 7 or 8 patients who went to ketamine clinics for their depression, some who also had ADHD, and actually only one or two of them had relief from their depression. So one thing that shows, again, with small numbers, and clearly the scientific data is supportive that the success rate's much higher than that. Maybe these individuals that I worked with were particularly resistant or particularly had some added factors or features going on. So I'd say be very wary of clinics advertising that they can effectively treat ketamine. They may be able to treat ADHD with ketamine. If they're really able to do it, they should be publishing studies confirming that that's what they're really seeing. So stay healthy, stay happy, and that's all.